Okay, fetal surveillance patient will generally first notice fetal movement like quickening at the 8 to 20 week gestational age in primigravida can occur 1 to 2 week earlier in the multigravida can occur 1 to 2 week later if placenta is implanted on the anterior wall of the uterus. If there is a concern about the decreased fetal movement, the patient is counseled to choose a time when the fetus is normally active to count movements, like usually recommended after 26 weeks. All high risk patients should be advised to do fetal movement counts, should experience more than 6 perceived movements in 2-hour period. If there is a subjective decrease in fetal movement time, how long it takes to feel 10 discrete movements lying on the left in the quiet setting can may facilitate feeling subtle movements. If 10 movements take more than 2 hours, further assessment is indicated, and the patient should present to labor and delivery triage for the assessment. Then comes the differential diagnosis of the decreased fetal movement is basically death, amniotic fluid decrease, sleep cycle of the fetus, hunger and thirst. Normal NST is basically 2 acceleration more than 15 bpm from the baseline lasting more than 15 seconds in 20 minutes. Then is basically non-stress test. Non-stress test is basically fetal heart rate tracing more than 20 minutes using a external Doppler to assess for the fetal heart rate and its movement to fetal movement indication. Any suggestion of the uteroplacental insufficiency or suspected compromise in the fetal well-being. Then comes the classification of intrapartum external fetal monitoring tracing is basically baseline variability, deceleration, acceleration, and interpret clinically. Then is basically baseline, which is basically normal tracing category 1, and it is 110 160 bpm. Atypical tracing is basically 100 to 110 bpm or more than 160 bpm for the 30 to 80 minute rising baseline arrhythmias. Abnormal tracing is basically bradycardia less than 100, tachycardia is more than 160 for more than 80-minute erratic baseline. So variability is basically 6 to 25 bpm, moderate less than 5, absent or minimal for less than 40 minutes. Atypical is basically less than 5 for 40 to 80 minutes. Then abnormal is basically less than 5 for more than 80 minutes and more than 25 bpm for more than 10 minutes and sinusoidal. Then comes the deceleration, which is basically normal tracing none, no non-repetitive uncomplicated variable and early decelerations. Then is basically atypical tracing, repetitive uncomplicated variables, non-repetitive complicated variables, intermittent later late deceleration, single prolonged deceleration more than 2 minutes but less than 3 minutes. Then comes abnormal, which is basically more than 3 minutes but less than 10 minutes. So recurrent late deceleration. Acceleration is basically spontaneous acceleration but not required. Acceleration with the scalp stimulation, and atypical tracing is basically absence of the acceleration with the scalp stimulation. Then comes is abnormal tracing, usually absent. Acceleration if present do not change classification of tracing. Then is interpret clinically. In the normal tracing there is no fetal compromise. In atypical there is like physiological change, maybe the mother has changed the side or fetus is sleeping or something like that. Abnormal tracing is basically fetal is getting compromised. On the side there is basically describing NSTs. Normal stress test is basically baseline rate, absent, minimal, moderate, marked variability, acceleration present or not present, deceleration early, late, and variable. Then is basically reassuring BPP, and which is basically check as limb extension or flexion, amniotic fluid index 2 into 2 centimeter pockets, movement 3 discrete, and then it comes is the breathing 1 episode more than 30 seconds. Then is basically false characteristic. False positive rate depends on the duration, false negative is basically 0.2. Then is basic interpretation. Normal is more than 32 week. At least 2 accelerations of the fetal heart rate more than 15 bpm from the baseline lasting more than 15 seconds in 20 minutes. Normal is basically less than 32 week. In less than 32 week, what happens is basically at least 2 acceleration more than 10 bpm from the baseline more than 10 seconds in the 20 minute. Abnormal is basically when the acceleration is less than 2 in the 40 minute, and when more than 80 minutes, so basically it's a problem. If no observed acceleration of the fetal movement in the first 20 minutes, then stimulate fetus like maybe fundus pressure, acoustic vibration, and continue monitoring for 30 minutes. Then comes the biophysical profile, basically ultrasound assessment of the fetus, like plus minus NST, like non-stress test we can do or we cannot do. Indication is post-term pregnancy, decreased fetal movement, IUGR, intrauterine growth restriction, or any other suggestion of the fetal distress or the uteroplacental insufficiency. In those, there is like limb movement, that is basically three discrete movements. Tone, basically at least one extension followed by one flexion. Breathing is basically at least one movement of the breathing lasting at least 30 seconds. Then comes the amniotic fluid volume, fluid pocket of 2 into 2. So there should be three discrete movements, at least one breathing and one tone of extension and flexion. And 8 into 10 with the normal fluid, or 10 into 10 is basically good, and intervention for the obstetric and the maternal factors. So 6 into 10 is basically with the normal fluid. Prenatal mortality is very like 9 into 1000. Determine that there is a functional renal tissue or intact membrane. If so, deliver fetus at the term, and then continue surveillance of the preterm fetus like less than 34 to maximize the fetal maturity. Then comes the 6 into 10 with the normal fluid. Prenatal mortality variable equivocal test. Repeat PPP in 24 hours, and then comes is like 0 to 4. And prenatal mortality is very common, like 191 to 600 in 1000, and consider delivery for the fetal indications like right away. Okay, then comes is basically counseling. Nutrition is basically eating a varied diet with the plenty of vegetables, fruits, whole grain dietary products, and the lean meats or the vegetable proteins. Caloric increase of 100 kilocalories in T1 and 300 kilocalories in T2 and T3, and 450 calories during the lactation. Daily like multivitamins with the folic acid should be continued during pregnancy. Nutrition is basically folate. Folate is 0.4 into 1 mg daily in all women placing starting 2 to 3 months preconception until 4 to 6 week postpartum, 4 mg if high risk of neural tube defect starting at least 3 month preconception until 12 week gestational age. Then continue 0.4 to 1 mg until 4 to 6 week postpartum or as long as the breastfeeding continues. So they have to take the folate. In the start there is 0.4 to 1, and then it grows up to like 4 mg, which is basically up in the postpartum and the lactational age. Sport increase in the blood volume and growth of the maternal and the fetal tissue, and decrease in the incidence of neural tube defect. Folate like rich foods, basically spinach and lentils, chickpeas, asparagus, broccoli, peas, Brussels sprout, corn, oranges. Calcium is basically 1200 to 1500 mg per day, and then maintain integrity of the maternal bones and skeleton development of the fetus and the breast milk production. Like vitamin D is basically 1000 IU, promotes calcium absorption, and iron is basically 0.8 in T1 and 4 to 5 in T2, and more than 6 should be in T3. So what is going to do is basically sport maternal increase in the blood cell mass, and sports fetal and the maternal tissue requires amount exceed normal body stores and typical intake, and therefore needs supplemental iron. So iron is the only nutrient for which the requirements during pregnancy and cannot be met by the diet alone. Essential fatty acids support fetal neural and visual development and maintained in the vegetable oils, margarines, peanuts, and the fatty fish. Then comes the caffeine is diuretic and stimulant that readily crosses placenta. Less than 300 mg per day is considered safe. Relationship between the caffeine and IUGR is basically unknown. So as small for the gestational age. States like 1 to 2, like Canadian Society for the Gynecologists states that 1 to 2 cups are safe during pregnancy. So on the side there is a sources of the caffeine. There is a herbal teas and the preparation. There is some herbal teas can cause toxic and the pharmacological effect, otherwise all the rest of the same. So raspberry leaf tea, what this causes basically used at term to promote labor. Herbal teas considered safe in moderation, like citrus peel, ginger, lemon balm, and linder flower, orange peel, and the rose hip. Then comes the foodborne illness. Basically in biological contamination of the food may occur through the cross contamination and improper food handling, like listeriosis, toxoplasmosis, and avoid consumption of the raw meat or the fish and the raw hot dog, raw eggs, and the raw sprouts, and unpasteurized like daily milk of the juices. Avoid unpasteurized like softy cheese, daily meats, and smoked salmons and pets, and they may be the source of listeria. Chemical contamination may be like with the mercury in the fish is not considered harmful, like zero point 0.5 is not harmful for the general population and including pregnant women. Health Canada advises pregnant women to limit consumption of the top predator fish is basically shark, swordfish, and king mackerel, and then tilefish. Then comes is the lifestyle. Lifestyle is like 150 minutes of the moderate intensity per walk. Talk test should be able to speak while exercising. Avoid supine position after 20 week gestational age. Avoid contraindication like ruptured placenta membrane, preterm labor, hypertensive disorders of the pregnancy, incompetent cervix, IUGR, multiple gestation, and then placenta previa after 28 week gestational age, persistent T2 T3, bleeding, uncontrolled type 1 diabetes mellitus. These all are the contraindication for the any exercise. Uncontrolled thyroid disease, cardiovascular disease, and respiratory disease or other systemic disorders. Relative contraindication is basically recurrent pregnancy loss, gestational hypertension, history of more spontaneous preterm birth, mild and moderate cardiovascular or respiratory disease. Then comes the symptomatic anemia, and then comes is basically anemia, and then malnutrition, eating disorder, twin pregnancy after 28 week gestational age, and other significant medical conditions. These are all relative contraindications. Then comes the weight gain, like optimal weight gain is basically 6.8 to 18.2 in the pre-pregnancy. Then comes the work is like strenuous exercises, extended hours, and shift work during pregnancy may be associated with a greater risk of the low birth weight and prematurity and the spontaneous abortion. Air travel is okay up till T2 and 36 to 38 week gestational age depending on the airline to avoid the giving birth on the plane. Then comes is the sexual intercourse may continue except in the patient at high risk like where spontaneous abortion, preterm labor, or placenta previa. And then breast stimulation may induce like uterine activity and is discouraged at the high risk patient near term. Then comes the smoking which causes the decreased birth weight like placenta previa, abortion, spontaneous abortion, preterm labor, and stillbirth. Psychosocial intervention considered first line nicotine replacement therapy or pharmacotherapy if counseling unsuccessful. Lower effective dose to minimize fetal exposure, intermittent dose preparation preferred, limited safety data for the bupropion or vernicline used during pregnancy. Alcohol no, so we can use bupropion, vernicline, and even NRTs. So then comes basically alcohol. No amount of alcohol is safe in pregnancy. Encourage abstinence from the alcohol during pregnancy. Alcohol increase incidence of like abortion, stillbirth, and congenital anomalies like fetal alcohol spectrum disorder. Then comes cocaine, microcephaly, and growth retardation, prematurity, and placental abruption. Then is basically cannabis, which causes smoke association with the low birth weight infants, and biosocial consideration discuss adjustment to the pregnancy like mood, work, stress, family, and the birth plan. Refer to the counseling and community resources as necessary. So on the side is basically weight gain. So in the start it's very much like up to 24 week it should be like 1 lbs, and then after 25 week it should be like up to like 0.5 0.7. Then comes this medication. Most common medication cross the placenta to some extent. Most drugs, and very few drugs are teratogenic, but very few drugs have proven safely in the pregnancy. Use any drug with caution, and if necessary analgesic acetaminophen preferred to the aspirin or bupropion. So then comes is like ACE inhibitors, which causes fetal renal problem. IUGR, oligohydramnios, carbamazepine causes open neural tube defect. Chloramphenicol is like gray baby syndrome. So ACE inhibitors, which causes fetal renal defects. IUGR, oligohydramnios, carbamazepine is open neural tube defect. Chloramphenicol causes gray baby syndrome. Lithium causes abstinent cardiac anomaly, goiter, and hyponatremia. Then comes the misoprostol, Mobius syndrome, and spontaneous abortion, preterm labor. NSAIDs is premature closure of the ductus arteriosus after 30 week gestational age. Prior to that, endomethacin used for the tocolysis. Then is basically phenytoin. Phenytoin causes the fetal hydrantoin syndrome, which is basically IUGR, mental retardation, facial dysmorphogenesis, and congenital anomalies. Like then comes the retinoids, CNS, craniofacial, cardiac, and thymic abnormalities. Then sulfa drugs, antifolate properties, therefore theoretical risk in the T1, risk of conditions in T3. Tetracycline is stain in infants' teeth and may affect long bone development. Valproate, congenital anomalies up to 9%, and then warfarin that causes development incidence of the spontaneous abortion, stillbirth, prematurity, IUGR, and fetal warfarin syndrome, which is basically nasal hypoplasia, epiphyseal stippling, optic atrophy, mental retardation, and intraocular. So, brain, mental, optic, and epiphyseal stippling, basically, and the nasal hypoplasia. Then comes the immunization. Administration is dependent on the risk of infection versus the risk of immunization application. Then is safe is basically tetanus toxoid, diphtheria and pertussis, influenza and hepatitis B. Avoid live vaccines like polio, measles, mumps, rubella and varicella. Contraindicated is basically oral typhoid, and the Public Health Agency of the Canada recommend all pregnant women receive the influenza vaccine. All pregnant women should be given Tdap every pregnancy irrespective of the immunization history, and ideally between 27 to 32-week gestational age, but can be given at 13 to 26-week gestational age if the high risk of preterm labor. Then we can give is like in the, is as soon as possible. Then is basically postpartum, and then rubella vaccine for all non-immune mothers if they have an adult booster and remain non-immune, but they should not be revaccinated, and pregnancy should be deferred for at least 1 month following pregnancy vaccination. So if somebody has getting rubella vaccine, so we have to wait 1 month before getting pregnant. So hepatitis B is vaccine should be given to the infant within 12 hours of the birth if maternal status unknown, or the his or the positive, or if father is known to have a chronic hepatitis infection. Follow up vaccine is basically doses is 1 and 6 month. Only vaccine required recommended is generally safe postpartum. Any vaccine, sorry, all the vaccines are present. Then comes the radiation. Then ionizing radiation exposure is considered. Ionizing radiation is exposed is causing teratogenic at the high doses if indicated for the maternal health should be done, and imaging not involved. Direct abdominal pelvic high dose radiation is not associated with the adverse events, and high doses of the fetus plain x-ray of the lumbar spine, abdomen और उसके बाद pelvis, barium enema, CT abdomen, pelvis and the lumbar spine. Radioactive isotopes of the iodine are contraindicated. No known adverse effects from the ultrasound or MRI is noted. So then there is values. So on the side there is like radiation in the pregnancy necessary amount to cause miscarriage is more than 5 cgy, and necessary amount to cause the malformation is more than 20 to 30 cgy. Then comes the antepartum hemorrhage. Definition is basically vaginal bleeding from the 20-week to term. Then basically differential diagnosis is basically bloody show, like represents cervical changes and early changes stages of the dilation. Most common etiology in T3. And then comes as placenta previa, placental abruption, vasa previa, and then cervical lesion and cervicitis, polyp, ectropion, and cervical cancer, uterine rupture, and then other is basically bleeding from the bowel, bladder, abnormal coagulation. Then comes is basically placenta previa versus abruptio placenta. Placenta previa is abnormal location of the placenta near, partially or completely over the internal os. It is basically idiopathic, and the risk factors is history of the placenta previa and multiparity and increased maternal age, multiple gestation, uterine tumors or other uterine anomalies, and uterine scar due to previous abortions, cesarean delivery, dilation, curettage, and myomectomy. Then is basically bleeding is basically painless. Abruptio placenta is premature separation of the normal implanted placenta after 20-week gestational age, basically idiopathic. Risk factors is previous abruption, maternal hypertension, chronic or gestational hypertension in 50% of the abruptions, or vascular disease. Cigarette smoking, more than one pack per day, excessive alcohol consumption, cocaine, multiparity or the maternal age more than 35 year, PPROM, and then rapid decompression of the distended uterus, polyhydramnios, multiple gestation, uterine anomaly, fibroid, trauma, motor vehicle collision, and maternal battery. Then is basically it is very usually painful. These all are the risk factors. Then comes is the placenta previa, placenta implanted in the then is basically placenta previa, placental implanted in the lower segment of the uterus. Placenta location is described in the relationship of the internal os as millimeter away or millimeter of the overlap. Painless, bright, red blood bleeding, recurrent, may be minimized and cease spontaneously but can cause catastrophe. onset of the bleeding is like 30-week gestation, but onset depends on the degree of previa. Then comes is basically physical examination. Do not perform digital vaginal examination until rule out placenta previa, like speculum or transvaginal probe are safe. Then uterus soft and non-tender, fetal parts are high, displaced, fetal move, heart rate is usually normal, shock and anemia corresponds to the degree of apparent blood loss. Do not perform a vaginal exam until the placenta previa has been ruled out by ultrasound. So then comes a complication, basically fetal perinatal uh, mortality low, but still higher than with the normal pregnancy. So it's very like mortality is still higher than the normal one. Prematurity, intrauterine hypoxia, fetal malpresentation, preterm pre-labor rupture of membrane, and then risk of the fetal blood loss from the pregnant placenta, especially if incised during cesarean delivery. Then is basically maternal, less than 1% maternal mortality, hemorrhage and hypovolemia, shock, anemia, acute renal failure, pituitary necrosis, and then placenta accreta, especially if the previous uterine surgery or the anterior placenta previa. Then comes this basically hysterectomy investigation is transvaginal ultrasound is more accurate than the transvaginal ultrasound at the diagnosis of the placenta previa at any gestational age. Spontaneous resolution is likely within the increasing uterine distension if the placenta recovers the internal os by less than 20 millimeter at the 20-week gestational age. Transvaginal ultrasound should be repeated in T3 as a continued change in the placenta location is likely. Then comes that management. Management is basically goal. Keep pregnancy intrauterine until the risk of continuing pregnancy outweighs the risk of preterm delivery. Then is basically stabilize and monitor. Maternal stabilization, large bore IV line with hydration, oxygen for the hypotensive patient, maternal vitals or urine output, blood loss, blood work, hematocrit, CBC, INR, PTT, fibrinogen, FDP, type and cross match. Electronic fetal monitoring, ultrasound assessment when fetal and the maternal condition permits, determine fetal viability, gestational age, and the placental location. We give ROGAM negative if mother is RH negative. Sorry, we give ROGAM if the mother is RH negative. Lehar-Betke test to determine the extent of the fetal-maternal transfusion and determine administer ROGAM at the adequate dose. 30 less than 37-week and the minimal bleeding, then we do expectant management and admit to the patient hospital, limited physical activity, no douches anymore or the sexual intercourse, and consider corticosteroids for the lung maturity and the delivery when the fetus is mature or the hemorrhage indicating maternal or the fetal compromise. Then more than 37-week gestation is basically delivered by the cesarean delivery. And then what we do is basically placental abruption. Placental abruption is partial or the total blood placenta detachment that is premature and caused by the bleeding at the decidual placental interface occur more than 20-week gestation age. Placenta detachment less than 20-week gestation is basically classified as abortion. Less than 20-week is basically abortion and more than 20-week is basically placental abruption or placenta previa. Then comes this clinically features total versus partial, basically fetal death inevitable in total, external revealed apparent, blood dissects downward toward the cervix, internal concealed and occult, blood dissects upward towards the fetus may or may not present with the vaginal bleeding. Most are mixed. Presentation is basically usually painful, 80%. Vaginal bleeding not always present if the abruption is concealed, uterine tenderness, uterine contraction, hypertonus, loss of relaxation between the contraction, pain, and sudden onset, constant, localized to lower back and the uterus, shock, anemia out of proportion to the apparent blood loss, fetal distress, and the fetal demise, bloody amniotic fluid, fetal presentation usually typically normal and coagulopathy. Then on the side is basically placental abruption is the most common cause of DIC in the pregnancy. Then is basically complication. What would be the complication? Complication is basically either fetal complication and then maternal complication. Fetal complication is basically death by like perinatal mortality like 25 to 60%, prematurity, intrauterine hypoxia. What happens in the maternal complication like maternal mortality, DIC, acute renal failure, anemia, hemorrhagic shock, pituitary necrosis, and amniotic fluid embolus. Then comes this investigation like ultrasound. It is basically clinical diagnosis and ultrasound not sensitive for the diagnostic abruption. So management is basically we give large bore IV line just like shock. We treat like large bore IV line with the hydration, oxygen for the hypertensive patient, maternal monitoring like vitals, urine output, blood loss, blood work, hematocrit, CBC, PTT, PT, and then fibrinogen, FDP, type and cross match, electronic fetal monitoring, and then blood products on the hand like red cell, platelets, cryoprecipitate. Because of the DIC risk, we have to keep all them in the hands. ROGAM, if the RH negative, clear Bethke test to assess for the ROGAM may confirm abruptions, and abruption without the fetal maternal compromise, mild abruption like less than 37, what we do is use serial hematocrit to assess for the concealed bleeding, and then deliver when the fetus is mature or when the hemorrhage desiccates. Then more than 37 is basically stabilize and then deliver. In the placenta previa, we were doing cesarean delivery in the more than 37. And then abruptio with the maternal, then is basically abruption with the fetal maternal compromise, moderate to severe abruption, that was like a mild one. Then comes the moderate to severe, hydrate and restore blood loss, correct coagulation defect if present, vaginal delivery if no contraindication and no evidence of the fetal and the maternal distress, cesarean delivery if the live fetus and the fetus or the maternal distress develops with the fluid, blood replacement, labor fails to progress if the vaginal delivery otherwise contraindicated. Then on the side is basically clear Bethke test is like quantifies fetal cells in the maternal circulation. Then comes is vesa previa. Unprotected fetal blood vessels pass over the vaginal os like associated with the velamentous insertion of the cord into the membranes of the placenta or succituate lobe. Then comes is like clinical features, painless vaginal bleeding and the fetal distress. If undiagnosed, 50%, what happens is like 50% mortality and increasing of 75% of the membrane rupture. Most infants die of exhaustion, exanguination. If diagnosed antenatally on ultrasound without labor or symptoms, then 97% survival. Investigation, what we do is APT test and the right test. APT test is basically NaOH mixed with the blood and can be diagnosed to determine if the blood is from the mother or the fetus. If the fetus, then it turns pink. If it's mother, then it turns yellow. Right blood on the blood smear, then look for the nucleated RBCs in the cord and not maternal blood. And management is basically planned CD or if bleeding, emergency CD. Since the bleeding is from the fetus, a small amount of the blood loss can cause catastrophic consequences. आ जाता है प्री लेबर रप्चर ऑफ मेम्ब्रेन. PROM है basically pre-labor rupture of membrane at any gestational age. Prolonged rupture of membrane, more than 24 hours elapsed between rupture of membranes and onset of the labor. So it is taking more than 24 hours and it becomes prolonged. Then comes like PPROM. So that is basically preterm pre-labor rupture of membrane like before 37-week gestational age. Then is risk factors. Maternal is multiparity, cervical incompetence, infection which is cervicitis, vaginitis, STI, UTI, and family history of PROM, and low socioeconomic class, poor nutrition, fetal congenital anomaly, multiple gestation, and other risk factors associated with the preterm labor. Clinical features is basically history of the fluid gush or continued leakage. So what happens is investigation, sterile speculum exam, avoid introducing of the infection, and pooling of the fluid in the posterior fornix, cascading, fluid leaking on the out of the cervix with the cuff and valsalva. So we do nitrazine test, which is basically basic amino fluid turned nitrazine paper blue. So low specificity as it can be positive with the blood and urine and semen. So it has a very low specificity. Then comes the furnic salt in the amino acid evaporates, giving amniotic fluid the appearance of the fern on the microscopy, and ultrasound to rule out fetal anomalies, assess gestational age, presentation, and biophysical profile. Then on the side is basically membrane status determined by pooling of the fluid on the speculum exam, increased pH of the vaginal fluid, nitrazine test, ferning of the fluid under light microscopy, and decreased amniotic fluid on ultrasound. So what comes is ferning, amniotic fluid is less, pH increase, and pooling of the fluid in the speculum exam in the posterior fornix. What is the management? Admit for the expectant management or monitor vitals every 4 hours. So we have to monitor vitals every 4 hours. Daily NST like non stress testing and WBC count, and then surveillance for the infection. Avoid introducing infection by minimizing examination. We can give metamethasone if it's preterm to accelerate maturity if less than 35-week gestational age with no evidence of infection. Consider tocolysis of for 48 hours to admit administration of the steroids if PP-prom induces labor. So basically preterm pre-labor rupture of membrane induces labor, and if it's more than 24 hours then that is basically prolonged. So screen for the UTI, STIs and GBS infection and treat with the appropriate antibiotics if positive. Treat GBS at the time of the labor. If not in the labor or the labor not indicated, consider antibiotics, basically penicillin or macrolide antibiotics as the treatment of the choice. So if it's not in the labor or labor not indicated, then we have to give them antibiotics. So if it's a rupture of membrane and it's not in labor or labor is not indicated, then we have to give antibiotics. Deliver urgently if evidence of the fetal distress or chorioamnitis. Then comes this PE-ROM. Prom management 22 to 25 is basically individual considering with the counseling of the parents, like regarding risk of the preterm infant. And 26 to 34 we can expect management as the prematurity complications, like we can give betamethasone and then wait for it. Then 34 autocolysis. Then 34 to 36 week gray zone where risk of the death from the RDS and neonatal sepsis is the same. So sepsis could be happening and RDS is like this risk is same. Then comes more than 37 week is basically induction of the labor since the risk of the death from the sepsis is greater than RDS. So 22 to 25 only counseling. Up to 34 week expectant management, and then 36 week both RDS and sepsis is the same, and more than 37 weeks basically sepsis. Prognosis varies with the gestational age. 90% of the patient with the PROM at the 28 to 34 week gestational age go into the spontaneous labor within 1 week. 50% of the patient with a PROM at the less than 26 week gestational age go into the spontaneous labor within 1 week. Compliance is basically called prolapse, intrauterine infection, premature delivery, limb contracture and pulmonary hypoplasia decrease at very early gestational age. Then comes this post-term pregnancy. This is basically pregnancy more than 42 week gestationally. So 28 to 34 weeks, we are not probably going anything. It could be spontaneous labor, so we can treat according to that. And then complications basically called prolapse. And one of the complication is basically vasa previa 2. I have read it somewhere. So complication is basically cord prolapse, intrauterine infection, premature delivery. Obviously, if the rupture is happening premature, then premature delivery. And then limb contraction and pulmonary hyperplasia, especially at very early gestational age. Then post-term pregnancy is basically more than 42 week gestational age. 41 week is up to 27%, and more than 42 is basically 5.5%. Most cases are idiopathic and an encephalic fetus with no pituitary gland, placental sulfatase deficiency, like X-linked recessive condition, and incorrect dates. So this could be any of the cause. Management of the singleton cephalic fetus otherwise uncomplicated, and the labor induction is recommended at 41 plus 3 week gestational age if no contraindications to the vaginal delivery. So labor induction is basically recommended at 41 plus 3 week if no like contraindication. Then prognosis is basically if more than 42 week gestational age, prenatal mortality 2 to 3 times higher. With increasing gestational age, higher rates of intrauterine infection. That's what's happening. Same infection, asphyxia, meconium aspiration syndrome, placental insufficiency, placental aging, infarction, macrosomia, dystocia, fetal distress, operative deliveries, pneumonia, seizures, NICU admission, and basically stillbirth. And morbidity is basically increased with the hypertension in pregnancy, diabetes mellitus, placenta abruption, IUGR, and advanced reproductive age, and the multiple gestation. So then comes is basically intrauterine fetal death, IUFD. So fetal demise in utero after 20 week is basically intrauterine fetal death. Before 20 week is basically spontaneous abortion. Then is basically etiology. 50% is idiopathic, 50% spontaneous, secondary to hypertension, diabetes mellitus, erythroblastosis fetalis, and congenital. Etiology में basically hypertension, diabetes mellitus, erythroblastosis fetalis और congenital anomalies, umbilical cord और the placental complication, intrauterine infection and APS. ठीक है. Clinical features में कहता है decreased perception of the fetal movement by the mother and symphysis fundal height and maternal weight not increasing, और फिर absent fetal heart rate, heart tone on the Doppler not diagnostic, and high maternal serum alpha fetoprotein on ultrasound, no uh, क्या था, no fetal heart rate depending on the timing of the death, may see skull collapse and brain tissue retraction, empty fetal bladder, no filled aorta, or the poor visualization of the midlife fox. Then comes the management, which is basically absent cardiac activity on fetal movement on ultrasound. So what we're going to do is basically it could be the secondary cause like HbA1c, maternal HbA1c, like fasting glucose, TSH, clear Bedke test, VDRL, ANA, CBC, anticardiolipin, antibody screen, INR, PTT, serum urine toxicology screen, cervical and the vaginal cultures, and the torch screen, and the fetus we will do karyotype, cord blood, skin biopsy, genetics evaluation, autopsy, amniotic fluid culture for the cytomegalovirus, parvovirus, and herpes. Then comes the placenta pathology and bacterial cultures. Then its treatment is basically more than 20 weeks. Then we have to do induction of the labor. Before that, we can give methotrexate and whatsoever. Then comes the monitor for the maternal coagulopathy, 10% risk of DIC, disseminated intracoagulation, and then paternal psychological care, bereavement support as per his hospital protocol and comprehension, discussion within 3 months about final investigation, and the postmortem results help make plans for future pregnancies. फिर साइड पे है DIC, generalized coagulation and the fibrinolysis. Then comes is like generalized coagulation and fibrinolysis leading to depletion of the coagulation factors. Obstetrical causes is basically placental abruption, gestational hypertension, fetal demise, postpartum hemorrhage. DIC specific blood work is CBC, APTT, and PT, and FTP, and fibrinogen. Then treatment is basically treat underlying cause, sportive fluids, blood products, FFP, platelets, cryoprecipitate, and consider anticoagulation as VTE prophylaxis. So then comes is basically intrauterine growth restriction. Estimated fetal weight less than 10 percentile for the gestational age on ultrasound, has not reached biological determined growth potential, 50%, and etiology is basically 50% unknown. Maternal causes malnutrition, smoking, drug misuse, alcoholism, cyanotic heart disease, type 1 diabetes mellitus, SLE, pulmonary insufficiency, previous IUGR, and chronic hypertension, gestational hypertension, chronic renal disease, prolonged gestation, and substance misuse, poor nutrition. Placenta, any disease that cause placental insufficiency, growth, gross placental morphology abnormalities, infarction, hemangiomas, and placenta previa, and abnormal cord insertion. Then comes the fetal causes, which is basically torch infection, any multiple gestation, and congenital anomalies and chromosomal anomalies. On the side, there is torch, basically toxoplasmosis. Others is syphilis, rubella, cytomegalovirus, HSV. And then clinical features is basically divided into two: symmetrical and asymmetrical. Symmetrical is basically type 1, occurs early in the pregnancy, reduce growth of both head and abdomen. Head ratio, abdomen ratio may be normal, more than 1 up to 32-week gestational age is equals to 1 at 32 to 34-week gestational age, less than 1 after 34-week gestational age, usually associated with the congenital anomalies or torch infection. Asymmetrical occurs late in pregnancy. Fetal abdomen is disproportionately smaller than fetal head. Brain is spared, and therefore fetal head ratio is increased. Head abdomen ratio is increased, and usually associated with a placental insufficiency, more favorable prognosis than type 1. Then complications: prone to meconium aspiration, asphyxia, polycythemia, hypoglycemia, hypocalcemia, hypophosphatemia, hyponatremia. So everything will fall down, and polycythemia is, so only the blood cells will increase. And intellectual disability, greater risk of prenatal mortality and morbidity. So investigation: Symphysis fundal height measurement at every antepartum visit ensure accurate gestational age. If the mother at higher risk or the symphysis fundal height lags more than 2 cm behind gestational age, ultrasound for the biparietal diameter, head and abdomen circumference ratio, femur length, and fetal weight, amniotic fluid volume decrease associated with the IUGR and decrease in the rate of the growth. Plus minus BPP biophysical profile and the Doppler analysis of the umbilical cord blood flow. And then is management. What we do is prevention via risk modification prior to the pregnancy is ideal. Modify controllable factors like smoking, alcohol, nutrition, and treat maternal illness. Serial BPP and determine cause of IUGR if possible, and then delivery when extrauterine existence is less dangerous than the continued intrauterine pregnancy. Abnormal functional tests like absent growth and severe oligohydramnios, especially if more than 34-week gestational age. So optimize fetus with the celestone, like giving oxytocin, and then magnesium sulfate for the neuroprotection, early GBS swab, and uh, pediatric consult if the anticipated preterm delivery. As IUGR fetuses are less likely to withdraw stresses of the labor, they are more likely to be delivered by the cesarean delivery.